Okay. Donna, you all set?
I'm all set.
Okay. Well, thank you everyone for joining us tonight. With us, we have Dawn Laney. Dawn lives in Atlanta, Georgia. She works with Fabry patients at Emory University. She's a coordinator on many clinical trials, an educator, and she does her own research on Fabry disease too. But Dawn has a unique gift. She's always able to take large amounts of complex information and make it very easy to understand. Um, Dawn was also the first guest on our new podcast. So if you haven't listened to it yet, check out the Fabre cast on any of the platforms you listen to your podcasts. So that's Fabre cast. So Fabre and then cast, C-A-S-T. So that's things like Amazon Music, Amazon Podcast, Apple Podcast, Google Podcast, really anywhere. It's on a lot of different platforms. So you can type in the Fabre cast on the search engine and you'll see it pop up. So we have 2 episodes already. So Dawn's our first guest. And then we have Dr. Khan, who is Ask a Doctor Anything. And our third one will be coming in March. So tonight we are learning about what the highlights from the WORLDSymposium are. The WORLDSymposium took place in early February, and I do think you will find a lot of encouragement and hope in what Dawn shares today, because there was a lot of information about Fabry, which means there's a lot of people interested and a lot of research going on. So Dawn, I'll hand it over to you.
Great. Thanks, Julia. This has been such a good exercise for me because I got to think about all the things that we watched and learned about at World, and then think about what does it actually mean? Because we see all of these posters with all this scientific information, and sometimes it takes a minute to actually figure out what it means to me when I'm working with people with Fabry disease. So I'm going to share my slides. Are you seeing notes or no notes?
No notes.
Okay, so just a big screen.
Yeah.
Perfect. Okay.
Or
All right.
no,
So
no, sorry. We're just seeing the Zoom screen so far with everybody on it. No, we don't see your screen yet.
oh, well, let's fix that.
Okay.
Let's fix it. We want to do this. All right, how
There we
about
go.
now?
We got it. We got you.
Yay! All right, so I'm really excited to talk to you today about this, and we're just keeping in mind that I do work with some clinical trials. I'm not going to share anything that wasn't talked about at World. Not that like there's any secrets or anything. It's just when you're doing clinical trial, you don't know what the final results are. So you kind of have to wait until they analyze data and tell you what the bottom lines are there. And also, even though I do spend lots of quality time talking about Fabry disease for multiple people, I try to make sure that I'm being as fair-handed as possible because we have lots of people working on therapies in the Fabry space, and sometimes they fight amongst themselves a little bit. And I'm going to try to give you like the middle line, like realistic what we're thinking from all of that. So just keep that in mind as we go through. None of this is medical advice. Are the slides going as I go?
Yes.
Perfect. None of this is medical advice. This is just kind of things I took from World that I think might be useful for you to know. So that's what I'm thinking of here. And all of it's about Fabry disease. If I don't put Fabry disease in the slide, feel free to ask me, is that about Fabry disease? But the biggest answer is going to be yes, because I didn't include anything else about other diseases at this point. Although sometimes I do if I think it's important to know about one of our cousin diseases or sister diseases. And feel free to put questions in the chat as I go along. You don't have to wait till the end. If there's something you want to know, just let me know. We've got plenty of time for questions. So that leaves plenty of time for you to think about it while we're going through. The first thing I want to talk about is actually out of the good work you guys have done in Canada. This is from the Canadian Fabry Disease Registry, and you'll see we'll have a couple different publications from this. So Canadian Fabry Disease Initiative, Canadian Fabry Disease Registry, all of those good things. This one is actually looking at, hey, do patients with Fabry disease have a higher incidence of chest pain? And clinically, we say that seems to be true, but they actually went through the data gathered in British Columbia to try to figure out if people are having chest pain, and if they are, what kind of chest pain is it? So they looked at 81 patients who said they'd had some chest pain, and this was not 81. Oh, well, it was both males and females in this study. And when they were trying to figure out who was having chest pain, they asked, do you get it when you exercise, when you don't exercise, or when you exercise or do exercise, does it still cause problems? And when I say exercise, I don't mean like running on a treadmill. I basically just mean like if you get up and walk a little bit, you're exerting yourself. And that's what they consider chest pain when you walk or chest pain when you don't, kind of things. So it was interesting because when people said they had chest pain, about 9% said they had chest pain when they did something. So walked, exercised, whatever. And it was more in males than females said they had that kind of chest pain when they walked. For people who said they just get chest pain anytime, doesn't matter if they're walking or sitting or watching TV or sleeping, it was 53%. So that's a good chunk of people. And it was about equal in men and women. They said they got this chest pain. But then a good 19% said that they had it sometimes when they're moving and sometimes when they weren't moving. So it was kind of just interesting to see because the other thing they did, they looked to see who had basically too much cholesterol in their arteries. They call that coronary disease, obstructive coronary disease. And if people had cholesterol in their arteries, then that was kind of an explanation for people who had some of this chest pain. But it was only 16% of people with chest pain who had that. So there's something else causing chest pain and Fabry disease. And there's all sorts of theories. There's a theory that the teeny tiny blood vessels that go to the heart sometimes that we can't see really well can get a little bit clogged or have problems, and that's what leads to chest pain. It could be that people who have enlarged left bottom chamber of their heart, so left ventricle hypertrophy, they can get some chest pain with that sometimes. But there wasn't a good answer for this paper. This paper was just figuring out, is it there? And what they found is that chest pain and Fabry needs to be studied more, and that there's definitely a subset of patients who have chest pain. So I wonder if you could put in the chat or even just raise your hand. Anybody here have chest pain that you've noticed with Fabry disease? Yeah, I see some hands. Yeah. So that's something that is now been identified as something that's in Fabry disease, and now something people can work on. Because I think the big thing is once we see if there's an issue in more than just a couple people, then we can spend the time and the resources to actually figure out what might be going on and how do we try to treat it. So it's kind of a stepwise product. First, is it there? Second, yeah, you too. Second, is it something that we really need to study a little bit better, understand why it's happening? And then third, can we treat it to make it better? The next one I thought was a really interesting study. It was about resilience in Fabry disease. And resilience is just how well you're able to adapt and recover after having stress, having adversity, having trauma, having tragedy. Basically, when bad things happen, how well do you snap back, or how well do you do in getting back to what your normal would be, whatever that normal might be? And the first thing they said is, well, what are factors that Fabry patients say make it harder to be resilient? So they said, how resilient are you? And they gave a questionnaire and lots of questions about, how well you snap back from things. And then they said, well, let's look at what's going on in your life and how Fabry is impacting you and see what makes you more or less resilient. So women are more resilient. Women with Fabry disease are very resilient. Women who were diagnosed younger, so have had longer to know that they had this condition, also are more resilient. And people who actually are trained and learn how to be resilient are more resilient. So that makes sense. So it makes you less resilient. Well, depression in males and females, pain, untreated pain, right? Pain that's constant. Getting bad sleep. So just not getting a good night's sleep can make it hard for you to be resilient. Stress, chronic stress, always being stressed, that'll make it hard. The more Fabry symptoms you have, and if you were diagnosed later in life as opposed to earlier in life. So I thought that was really interesting because if you look at the things that make it harder to be resilient, some of those things we can do things about, right? We can treat depression, just like we treat protein in the urine, we can treat depression. Does it take some work? Yes. Does it maybe mean you will learn some techniques to help you? Yes. Does it maybe mean on medication? Yes. But if you could help treat depression, then you can help your ability to recover from traumatic events or tragedies or just daily stressors. Or sleep. There's actually sleep therapists, and their job is to figure out why you can't sleep and then figure out, ways to help you sleep and almost train your body to sleep better. So these are things we could do a little something about. Can we fix your more Fabry symptoms? No, but we could hopefully work with your healthcare providers to, treat some of them or make some of them a little bit better. I can't promise you they're going to go away, but there are things that you can work on one by one to kind of make it a little bit better and then maybe help with resilience. So the bottom line from their project was there are resilience enhancement programs and people with Fabry disease should be given access to them. These aren't programs that are involving medication. They may not be within a hospital, but they could be. But they're really focusing on building your skills so that you can help yourself be more resilient emotionally, within your thoughts, and also physically. So interesting, right? We haven't heard much about resilience. And I thought this was great because it did say there is something we can do, and these are things that make it worse, and these are things that can help you. So I like that. Vera, did you have a question, or are you just agreeing from before? I'll keep on and you interrupt me if you do have a question. Okay, this was amazing poster, and it was spearheaded by an amazing advocate in Fabry disease. Your own Julia Alton had a wonderful poster that had a lot of really great graphics, and it was really well laid out, and it made this important point that women with Fabry disease, both in the US and in Canada, are facing a lot of challenges, and they have concerns as well as challenges. And I sum them up for you here, which is that concerns women are having, whether they're in Canada or the US, are that they're worried about their disease symptoms. They're worried about the impact of Fabry disease on their life, their quality of life, and they're worried maybe they're not getting the best disease management and treatment. Because one of the things that was highlighted really well is that many of the women felt that their care is very different than that received by men. So 44% of women in Canada and 80% in the US said, my care is different. And then they went on to say and agree that they felt their symptoms were not being taken seriously. And they had disparity in care. So they weren't getting the same amount of care between themselves with Fabry disease and men with Fabry disease. And I thought that was really telling and really interesting, because if you're going to a medical appointment feeling like, okay, this is what I think I need out of this appointment, and this is what I feel I should talk about and what should be happening, sometimes you're not getting that. And sometimes you feel it's because you're a woman with Fabry disease instead of a man with Fabry disease. And I would say this is probably in pretty strict contrast if you're a woman with Fabry disease who accompanies men in your family with Fabry disease to appointments, because you see how they're handled and how you're handled and how your management may differ or treatment options may differ than what they're offered. So the poster wasn't about that piece, but next steps. The other thing that I thought was really interesting is one of the most stressful times that women said was happening in their life was during family planning. So deciding to have children, deciding in which way you'd like to have children, and thinking about Fabry and its impact on your children. So all of that was seen as the most stressful time for women with Fabry disease. And I think, as we know, and we'll see in a couple other of the studies from World, that Fabry disease really does affect mental health. And definitely for women as well as men. And when we look at our primary healthcare physicians, they may not understand how Fabry may uniquely impact women, whether it's for mental health or physical health or therapies, or being this sandwich generation with children who have Fabry and maybe other family members with Fabry disease and being a caretaker. So the conclusion was really important, which is that more research is needed to understand and holistically meet the needs of women with Fabry disease. And I think, again, just like we talked about with things that are physical, we really need to understand for women what's missing in their therapy and what's missing in their care, and then we can work on fixing it. So we've got this great study that tells us there's problems, and it points out exactly which problems need a little fixing. And then next we can start working on that and getting this information out to healthcare providers and really sharing it with them and saying, okay, how is this different? Can you tell me how this is different? And really being a partner with our healthcare providers to help them help you get better therapy or feel better about it, This study I thought was fascinating. Hopefully you guys think it's fascinating as well. So this was a study out of, where were they? This was a Danish study, right? So they were out of Denmark, and they looked at their patients with Fabry disease, and they asked the question, should we automatically be doing an echocardiogram on all of our Fabry patients every year after they start therapy? And what they did is they looked at all of their patients and all of them who had an echo before they started therapy. And then they looked at all the scans over the years they had gotten therapy, about 20 years of people getting followed for Fabry disease in Denmark. They said that about 15% of males and 18% of women did have that enlarged lower chamber of their heart, the left ventricle hypertrophy. And even in those people who had had that problem or had not yet had that, they didn't see any significant change in the size of that left ventricle. They didn't see a change in their diastolic dysfunction. Diastolic function is when your heart relaxes in between your heartbeats, and it's common in Fabry to have abnormal relaxing of your heart chambers in between heartbeats. They didn't find any change in that, and there's only minor number change in how big their left ventricle was. Their conclusion wasn't no more echoes for everybody. Their conclusion was we need to be a little bit more focused and personalized on how we decide what to do, what tests with which people. Are there certain people we're more worried about and we should do annual echoes on? Probably. Are the people we're less worried about and we don't have to do every year echoes? Maybe we can do every other year echoes? Maybe. Their conclusion, though, is we need to spend more time thinking about the individual and what tests they need, and less just automatically doing things. I'm not sure how I feel about that. I feel like sometimes when we talk about doing it annually, it's because do we really know who might be having more problems or less problems? So my editorial comment on this one was, if there's no change in all these people over 20 years of therapy, maybe we're not doing the right test. Maybe we need to be doing cardiac MRIs, maybe not every year, but maybe that would give us more information about small changes that are happening in the heart, as opposed to an echo, just a standard echo, which maybe is not sensitive enough to catch what we'd like to see. I know that sometimes with later complications in the heart, things can progress, like sometimes when your valves are doing regurgitation, that can progress faster than we catch on an echo, but we can see it on a cardiac MRI. So their conclusion was more individualized, monitoring plans. Mine is maybe we need to find some other measurements or other tests that, an echo, you can do different types of tests, and maybe one of those would be better in analyzing things instead of just measuring, the size and the ejection fraction. So I don't know. We'll have to wait and see, right? When all the experts get together and talk about the heart tests again, they'll take that into account. I also wanted you guys to know that there were so many posters this year that were really trying to understand from patients with Fabry disease how they're feeling about therapy, how they're feeling about the journey, how they feel about the impact of Fabry disease on mental health, how do they feel about their therapies, all of these different things that were posters, that were surveys of what people with real life Fabry disease were talking about. So not just the experts, not just looking at data. These were really asking people with Fabry disease about the impact of Fabry on their life. And so I'm not giving you the details on each of these, but I just wanted to kind of tell you what it was that we really got to learn specifically from patients with Fabry disease. One is just, what is it like to have Fabry disease from the time of diagnosis to getting on therapy? So they asked kind of general questions about the length of all these things and how you felt about all these pieces, the impact of pain, things like that. There were several posters on living with Fabry disease and the chance and risk for depression, the impact of having Fabry on your quality of life, the impact on having anxiety, and the impact overall of just what are the things that get in the way when you have Fabry disease. I love this poster. There was a poster that was trying to find ways to help families talk to each other a little bit more about Fabry disease, and then make sure that like one cousin has let the other cousin know that they're at risk for Fabry disease and get them diagnosed and treated earlier. And I was like, yeah. And they listed all the reasons why that doesn't work sometimes, like all the reasons your families don't get along, and just how you could get around some of that to really make sure families are telling each other that this is something we need to talk about, something we need to think about. Let's talk about it a little bit. There was a great poster with really pretty graphics. It was just well done about if people feel like wearing smartwatches to measure certain things about Fabry disease, is that a good thing? Is it useful if you can fill out questionnaires online before you get to your doctor's office? Jack had a question about ERT in Denmark. It's a mixed bag, Jack. They do both egg alcidase beta and egg alcidase alpha. So kind of like Canada, they have the same sort of thing where they do both. I'm not sure what they're on more of, but I can understand why you're asking that question if certain therapies might not be causing change in the heart versus the other. They're a small cohort though. If you think about that was the number of patients in the entire country. And you think about it as it like the number of people in Canada with Fabry, the number of people in US with Fabry disease, they're kind of like a province or a state in their size. But it does mean that usually one group is taking care of all the patients, which is good for research. Okay. Oh, so portable technology, really trying to see if we can use, if patients are okay with using things that you wear to give little bits of information. They had like a, you know how you have to wear a Holter monitor sometimes, that's all the sticky things on it. They were looking at a wearable patch you could put on yourself and wear just, you know, for a couple days a month and then not have it and then put it on again. So you can give that information to your doctors. Or if you know there's a time a month or a thing you do that tends to make your heart beat a little irregular, you're worried about a rhythm change, you can wear one of those. And it was asking, do people like that idea? And really, most people seem to think that wearable stuff is good. We could get some good data to doctors. One of the concerns was, can the doctors access and look at it? Because as you know, if you've got lots of pieces of data, your physicians may not be able to access that and pay attention to it in between your appointments. They may look at it at the time of your appointment or before your appointment or right after your appointment, but may not be monitoring everything all the time. So that's kind of the question is what's the balancing point between too much data, too little data, and useful data that can be, you know, kind of a conversation in between visits between you and your doctor. And then they had some questions about how do people feel about treatment? Do they feel it's being helpful? Do they think it's not worth the time invested? How do people feel about doing infusions once a month versus twice a month? Just kind of learning from you guys what it is you're thinking about therapy and about the impact of Fabry. So I just wanted to give you a little sampling of what they told us and what we learned about those topics. And it was, I just want more of these. I want more studies like Julia's, more studies that are really learning from people with Fabry disease about different topics. All right, I'm going to transition. Does anybody have any questions so far on what we're talking about, which was kind of natural history sort of thing? So things about Fabry disease. Every year there, oh, yeah. Okay, yeah, so Sandy had a question. Can you please explain again about left ventricle hypertrophy and development of valve issues? Did you say valve issues are developing faster than left ventricle hypertrophy? Okay, so let's talk about what these all are. So left ventricle hypertrophy is when the bottom left chamber of your heart gets really thick, and it's thick because it's pushing so hard to get blood out, and it's getting blood out to your body. So when your left ventricle is getting tired and worn out and thick, that means some of those cells may start dying and then you get scarring. We know from a cardiac MRI that we can see some scarring in your left ventricle before we see the actual enlargement that is getting big, that is becoming left ventricle hypertrophy. So that's one thing that's different between an echo, which just tells you if the chamber is big or not, versus a cardiac MRI. So when I say in that study from Denmark that left ventricle hypertrophy didn't change much, it's a good thing. In Fabry disease, we're happy if something stays stable. We're not sad, but would we like it to be a little better? We would. But scarring can't be changed. So if it's left ventricle hypertrophy, but there's not, you know, the cells that aren't scarred, maybe we can't help those, even if we can't help the few that are scarred. And when we help the left ventricle, then we help our heart relax and then beat blood out to our body. It makes our heart stronger. In this case, for our heart, bigger is not better. Separate issue. Some people with Fabry disease have aortic valves or mitral valves. And these are the valves that are either between blood going out to the heart or the two chambers of the heart. And sometimes you can have regurgitation. A little bit of regurgitation is okay, but what it means is every time your heart beats and it pushes the blood in the next place it's supposed to go, some may come back a little. And you don't want it to come back a little because that means that, you know, if we're pushing it out to the lungs, not as much as we want going out to the lungs is going to the lungs. So we're going to have to push it again next time. And if we're talking about the left ventricle, we're talking about if you have regurgitation back, then it means that not all the blood that has oxygen is going out to your body the way that it should. It's sitting there and hanging out as your heart relaxes. When we look at your valves over time, usually you don't see fast change. It doesn't go from mild to moderate over the course of a year. It doesn't go from moderate to severe really, really fast. But we did find in some of our older men with Fabry disease, so guys who have been on therapy or off therapy, sometimes the valve can be getting a little bit, having more regurgitation. It's a little bit stiffer, so it's making a little bit more regurgitation. It can get worse a little faster than we can track with an echo. It's on the cardiac MRI, we can see that the valve is starting to get really thick and it's letting more blood go backwards than we want to. And sometimes it can go from a moderate to a severe much faster than we can expect. And the symptoms of that are sudden increased shortness of breath, sudden, like you can't walk as far as you can without sitting down, so you just get even tireder faster. And sometimes you can retain more fluid in your abdomen and in the area around your heart. So what we really want to know is if somebody is at risk of their heart valve going from moderate to severe or severe to profound, that we're looking at it with the best test and we're doing it in the right people. So I would argue that's a cardiac MRI, and many of our gentlemen and ladies who are maybe like 50 or 60 plus and have moderate valve regurgitation already, if you've got trace valve regurgitation or mild regurgitation, it would be really, really weird for it to get really bad really fast. But if you're farther along in your Fabry journey and you maybe didn't get therapy until you're a little older, and you already have moderate or severe valve issues, those are the people we need to watch much closer. And I think you've got to use an MRI instead of echo. Now, I'm not a cardiologist. I'm just, putting together what I know from several case reports I've seen and several cardiologists I've talked to, talking about the benefits of these different tests, and that they have seen some of these valve diseases that were already pretty far along get much faster, worse faster. So again, I don't want you to worry that this is something that if you've got mild or trace valve regurgitation, that it's going to be bad really fast. But the thing is, if you know that a valve is having big problems, you can do replacements and therapies early in the process than you can later in the process. So you don't want things to progress to the point where you're no longer a candidate to be able to use laparoscopic surgery to replace the valve. That you'd have to do open chest surgery or have to do some other, have to do some other debulking before you can get a new valve. So it's all a matter of monitoring and then getting the best treatment at the right time for you before it progresses and gets a little worse. Did I answer your question, Sandy? That was a long answer, I know. Okay, thank you. Okay, so let's talk about therapies that are approved. There were not as many studies about our therapies that are already on the market. There was a lot of discussion, though, about changing from enzyme replacement therapy to Galafold. There were 3 or 4 posters and a couple presentations on this topic. So what they were looking at is people who've already been on enzyme, and then on because different studies did different amounts, but they were saying, all right, there are these people who've been on enzyme for mostly about a year. There was some that may have been a little bit less, but mostly about a year of enzyme replacement therapy. They felt their biomarkers were stable, they were looking good, and then they switched to Galafold, or megalostat. So, that's enzyme replacement therapy to chaperone therapy. So not everybody can take chaperone therapy. So these studies were just on people who had what they say amenable variants or amenable mutations to Galafold. So Galafold should work for them. So they didn't put anybody in these studies where Galafold would not work. And so it's interesting because people got slightly different results when they looked at it slightly different ways. So the first one I put up here is that there is a brilliant, brilliant scientist that lives in Montreal. Her name is Christiane Ari-Blaise, and she does a lot of work with GL3 and lyso-GL3 in blood and urine in people with Fabry disease. So you probably all remember, but in every cell of our body, we've got the lysosome, and the lysosome, there's enzymes that break things down. If you're missing alpha-galactosidase A enzyme, then you have Fabry disease, and that means things like GL3 or GB3 and lyso-GB3 build up in this lysosome and cause problems. And so one of the things that we try to look at to see how well therapy is working is lyso-Gb3 or GL3 in the blood and in the urine. And that's what she is really good at. She's a biochemist. She works really closely with lyso-Gb3 or lyso-GL3. It's the same thing in patients who have Fabry disease. So she said, okay, give me a lot of urine and give me a lot of blood from people who have Fabry disease, who were on enzyme replacement therapy. Then they switched over migalastat and either enzyme replacement therapy, Replagal or Fabrazyme. And how does it look in their biomarkers? Now she does the total plasma lyso-GL3 or lyso-Gb3 and the all of these little special, little slightly different forms of it. But this was mostly on the main form. And she said for most part, biomarkers were stable in people who switched from enzyme replacement therapy to Galafold. There are a couple people who got a little better, some people who got a little bit worse, but on the whole, she felt the switch was well tolerated, so things were okay. Then we look at our Canadian Fabry Disease Registry. So that's our project that all of you participate in for the most part. And they looked at switching, they had a population of people, some who started on Galafold and some who switched from one of the enzymes to Galafold. And what they found is no statistically significant differences observed in people who changed, even if they had more severe kidney disease or less severe kidney disease. They didn't see a significant change in how well their kidneys were functioning as measured by the GFR, which is the glomerular filtration rate, which is how well they estimate your kidneys are working over 5 years. So they felt their data was saying that switching was cool too. Then there was a study that was, this is a Sanofi study, and this one was looking at the registry data. So this is kind of like the Canada Fabry registry, except this is around the world. And it's looking at people who changed from Fabrazyme to migalastat. So again, Fabrazyme to Galafold. They said that they saw worsening in the glomerular, the GFR, and they saw worsening in GL3 for some patients who have classic Fabry disease. But they did see that for some later onset patients, like patients with N215S, which is a really common mutation, they saw stabilization and some improvement in cardiac measures. So their bottom line is, just because it says you're amenable, you've got to look at the patient and you've got to see how they individually are doing. You've got to measure how their heart is, how their kidney is, and how those biomarkers, those GL3 levels are. Because depending on who the patient is, they saw some people who didn't do well and they saw some people who did great. And what they're saying is just monitor and be careful. So different approaches from 3 different sets of people, 3 different populations, all saying some people seem to do really well when they switch from enzyme to Galafold. Some people you need to watch because they may not be doing as well. And that varied depending on what kind of gene change they had that caused their Fabry disease. I don't, Julia, is Elfabrio approved in Canada? No. Okay, so this is this is Elfabrio or pegunidase alpha is its generic name. This is something that's approved in the US, but not approved in Canada. But this is an enzyme replacement therapy that has been in clinical trials for a while. And I shared with you guys last year some of the trials that were looking at changing from agalsidase beta or agalsidase alpha, Fabrazyme or Replagal, to this Elfabrio medication and the studies they showed. And then using those studies, they got approved by the FDA and it's available now in the US here. But this particular presentation was basically about infusion reactions. And what they were looking at is all the studies they've done in the US and around the world, how many patients had infusion reactions, and of those patients who had infusion reactions, what made it more likely someone would get an infusion reaction? So they said that less than 1/3 of patients had infusion reactions on all of their studies. They said there was no increased infusion reactions with a higher dose. So, you know, if somebody was getting, 1 milligram per kilogram versus 1 milligram per kilogram or 2 milligrams per kilogram. And they found that infusion reactions were more common in men and people who had antibodies that were positive to agalsidase before they started the study, which kind of makes sense, because men have, depending on who you are with Fabry disease, but many men don't have any enzyme at all. So if you give them an enzyme replacement therapy, they're more likely to have a reaction. And then people who already have antibodies may be at increased risk to have reactions. We do also know that there were a couple people in the study who got Elfabrio or pegunidase alpha who had immediate reactions like shortness of breath or things like that. And those are people who didn't have this kind of antibodies, but had different antibodies. And that was why they said when it was approved in the US, you know, you can decide as a doctor, but you should probably do the first infusion in setting like an infusion center or hospital. So if there's any problems, you can quickly address it. But that was pretty rare, even across all the studies. Okay. So now the big stuff, right? What's in clinical trials? What's the new stuff coming? Did we learn anything new about gene therapy? And the answer is we learned about gene therapy. So I'm going to share what we learned about gene therapy. But first, I'm going to mention there's a couple studies that are enrolling now. One of the studies that's enrolling is a substrate reduction therapy. And I put up a picture on this slide, a picture of what happened in Atlanta a little while ago, where we had a fire underneath our expressway and the expressway collapsed. And I want you to think about that like Fabry disease. If in your body, when you have Fabry disease, that blockage, that enzyme causes your expressway to get those things broken down, it collapses, then what do you end up doing? Well, if you were driving down the road in Atlanta, you would take an exit and you would go on one of the local roads, right? You would get around the big blockage. Substrate reduction therapy, the goal is to get around building up all those GB3s behind your enzyme blockage in your body and use earlier pathways to see if you can break down GL3 before it gets all stuck and built up behind the enzyme that's not working. So substrate reduction therapy, it's a pill study. And currently they did a phase 2 study already that was done several years ago. And from that study, they felt that the medication was safe in patients with Fabry disease. And now this study is designed to figure out how well it works. So they're doing two things. One of them is if you take this pill called venglustat, is it better or worse effectively than being on enzyme replacement therapy or Galafold? So they're taking people who already have left ventricle hypertrophy, and then they're randomizing them to either be on the treatment they're on right now, although it's paid for by the study, or taking substrate reduction therapy and seeing what impact that has on their heart. So that has lots of cardiac MRIs in there. So that's one study. You also have to have never had a stroke or a kidney transplant for that study. The other study is people who have never been on therapy or have been off therapy for at least 6 months, and they get randomized either to taking the study drug or basically taking a sugar pill, what we call placebo. And for 12 months, they compare people's pain in their belly, their abdomen, and their neuropathic pain, so their burning pain in their hands and feet, to see how it changes and if taking this medication improves that over time. After 12 months in both these studies, then you roll over to taking the real study drug if you want to. So we don't have any results for these yet because we just got the phase 2 results, not too long ago. And now we're looking at in Canada and in the United States, enrolling patients on these studies to try to figure out if it works for people with Fabry disease and if it's as effective as the currently approved therapies, to see if it's better or worse. And then if it seems to directly help for nerve and GI. One of the unique things about venglustat is it does get across into the brain. So there's the question of, does it help also with other things related to the brain? These are not endpoints they're following, but they are going to ask about quality of life throughout these studies. And these studies heavily rely on asking you questions in like a phone app. It's not really a phone app. It's just a special device that asks you questions. It looks like a phone, but, but there's lots of answering questions in these applications because they really want to know how things have improved or not improved from the perspective of the patients, which is what a lot of the regulatory people that approve drugs want to know now. So those are up and running. So if you're interested in any of that, you can talk to your doctor about where it's happening. This study, I think, actually may only be in the US, but they're trying to, in an orderly fashion, figure out, this is Sanofi, if they can speed up infusions with less volume in a safe and effective manner. So really, they're just taking patients who are on a galsidase beta and giving them a reduced dose, or same dose, but reduced amount of fluid and less time to see if they can make it happen without having infusion reactions or any other negative impact. So we'll see. All right, gene therapy is the exciting stuff, right? Okay, so gene therapy, one of the data sets that were presented at World in the big room with all the people watching was from Sangamo. They have a product, and what it is they basically are taking a virus or an adeno-associated virus. It's just another name for a virus. They're taking all the bad stuff out, and they're sticking the GLA, the gene that makes alpha galactosidase A, or the GLA gene. They're sticking that in this virus. So now the virus we call a vector, and the little piece of DNA will go into the body, and they're targeted to go to the liver, because the liver has a lot of blood vessels and can get stuff throughout your body. So the goal is to take, we call it a vector, now that it's the virus plus the gene, but we call the vector is the virus. It's targeted and takes itself into your liver and tries to infect all the liver cells it can. And what it does when it infects the liver cells is it sticks that little circle of DNA in all the cells that can infect. Now that little circle of DNA is going to stay in your liver cells, and its job is just to make enzyme, make alpha galactosidase A enzyme, the stuff that you're missing in Fabry disease. It just makes it, all of it, so much of it, and then sends it out to your bloodstream through the usual channels you would from your liver. So there's a couple of things you need to do. So when this is a study that's phase 1/2, which means it's the first time in humans with Fabry disease, and they need to figure out if it's safe, and they need to figure out if it's effective. So to figure out if something is safe, they give this a one-time infection, if you will, one-time infusion of this product. And then they see what the body does. What do people who get this, how does their body react? Does it cause problems? Does it help increase enzyme? And does it either decrease that GB3 or that lyso-GB3, or does it keep it stable as it was when they're on therapy? Because people in this therapy could either be not on enzyme or on enzyme before they started. Okay, so these were the results they presented, and this is the first time we've gotten so many results here. So if you look at that graph that's called plasma alpha galactosidase A activity, what we want is those levels to be basically higher than they started at and above that blue line. Now that blue line, that like big blue line, that's actually the normal range. So if you were to measure my blood and say, what's Dawn's enzyme level? I'd probably be right there around that dotted line in the middle, because that's the average person's level of alpha galactosidase A. Now, if you have Fabry disease, you'll see on this graph, they're below the blue bar. And that's women and men with Fabry disease who are in this study. And each of those lines, each color represents another patient who was given this therapy, this gene therapy, and what happens to their enzyme. So if you just pick one, so pick one to follow. Let's pick purple. So purple started out, well, purple's hard to see starting out, but so purple started out below the blue bar, like the lower limit, because they had not much enzyme in their body. Then they got their infusion at 0. You see that 0 on the bottom there? And see that purple went up, 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 way over the blue line. So their levels of enzyme are higher than even mine and your average person living without Fabry disease. And you can see it stayed up above that blue bar all the way out until, depending on who you are, with purple people, it was 350 days. So that's almost an entire year of having above normal levels of enzyme. So that means this gene carried by that virus got into the liver and did what it was supposed to do. It made the enzyme. And you can see that story plays out for almost every person up there. And that person who's yellow, look how high their enzyme is. It doesn't cause problems when it's that high, but you guys, that is incredibly high. You can see that a bunch of people who got dosed more recently are in the blue bar or a little bit above, but they're not as high as yellow, right? So we'll just say that yellow did like a supremely good job of accepting that, that gene therapy, while everybody else is still well above where they started, and everybody is staying above where they started as they go further down. So you can see the weeks out. Now, all of these people still have at least, you know, this is a 5-year study. So what they need to figure out is how long does it stay up like that? How long is it higher than your average level? Because if it starts dropping down back to where they started, then that'll be time to go back on enzyme replacement therapy or whatever therapy they were on before. The other thing I want you to look at is up in that upper sab. You see that plasma lyso-GB3? What you want to see here is you want things to go down for the people who were not on therapy before, or you want them to stay stable if they had been on therapy before. So I think the best example to look at, take a look at subject 8. They've got the red triangles, and you can see when they started therapy, their lyso-GL3s were about at 20. And then as you go out to 450, you can see basically they didn't go down very much, but they were stable all the way out. And that's what we want to see. We don't want to see the lyso-Gb3 starting to go up without going back down again. We do want your alpha-galactosidase A up, but you want your lyso-Gb3 down or flat. Now you'll notice nobody's got to 0. So the only time in Fabry disease when you're treated that we see it get to 0 is if you're a young kid and you start therapy early. And there's been several publications that show that's probably the only time you can get your lyso-Gb3s all the way to 0 or undetectable. But from the perspective of so far, is this therapy seem to meet its goals of getting your alpha-gal up and your lyso-Gb3 down or stable? It seems to be doing a good job. Now, these are just things you measure in blood, and the most important things will come next when we look at how their heart does over time on the MRI and how other factors do, like quality of life and how they're feeling. Now, the other part of what we were doing was safety, right? So when we talk about safety, we want to know what happened when we gave people this infection, right? Gene therapy is basically an infection. It's just a good infection. So what happened is people's immune system reacted just like they would if they got a cold or a fever or felt like they were starting to do something their immune system didn't like. So people got fevers, they got headaches, somebody got COVID, that had nothing to do with the infection. Sometimes you just have to report things that happened during meeting. People got tired, they started to have like snotty nose, kind of irritated sinuses, diarrhea, decrease in blood pressure, nausea, joint pain, viral infection, muscle pain, and neck pain. And all of these, if you'll see, these were all mild, because when you look at grade 3, 4, because that's the most severe issues, then you'll see that mostly people had more severe things were either fever or muscle pain. Nobody dropped out of the study. When you do a gene therapy, we can't take the vector, we can't take the gene back out of you once we gave it to you, but nobody's dropped out of the study. And only one person after this, Dr. Hopkins mentioned, had to take steroids because their liver functions had increased a little bit. So in general, this is considered not bad. Now, this particular treatment, they didn't give any medications to decrease your immune system before you got the treatment. So I don't know if that would be different if they go into their next phase of the study. But we do know that this was reported at this study and looks pretty good. Somebody just asked, does our genetic specialist get all the information you're giving to us from the world? They get, yeah, they can access all of it. And I'm putting little links at the bottom of all these pages you can see so you can look at it too. If your genetic specialist went to the meeting or read up on the meeting, then they'll have this information. If they haven't been to the meeting or read up, but they may not have all this information, but they will know about, clinical trials and stuff, and they can always, look it up and they can see it too. It just depends on if your specialist is able to dig in deep with Fabry or not. If your specialist does a lot of different things, sometimes they can't pay as much attention to the latest and greatest in Fabry, but they can always look it up for you. Okay, so that was one company, that was Sangamo, right? So there's another company that's been doing gene therapy. They're called 4D Molecular Therapeutics, or 4DMT. And they also do a one-time infusion of a gene therapy, and they also do it in their own special virus or AAV, and they also put their little gene in there. But instead of being targeted only for the liver, this one is more targeted to the heart. And because you can target a virus to different parts of your body, think about how you get like the common cold, it's different each time, right? Same thing happens with these viruses, these vectors. Even though we're doing gene therapy, which is infection for good, they can still use a particular targeted virus that heads toward the heart or the liver or the brain. In this case, they're really focused on delivering things to the heart, and they also gave a little bit to the liver as well. So this is particular gene therapy is called 4D310 because they don't get good names until later. And what they did is they did this study in men and women who had Fabry disease and had been on a stable dose of enzyme replacement therapy for at least 6 months, and then on therapy for at least 12 months. And then they couldn't have neutralizing antibodies to the AAV. So you can't already have an immune response to the virus they're giving you. And that's true for both the studies. Okay, so they enrolled 6 patients. They treated them and they did a pre-steroid. So the steroid dampened your immune system. So they did that before they started the gene therapy. They're working on changing that, so they're going to give a different immune therapy before they do more infusions, and I'll tell you why in a sec. They did, for the patients who were treated, they saw from their echo an improvement in one of the things they measured. So they measured what's called a global longitude strain, or GLS. But basically that's like how long or how affected are the heart when they relax. So remember I talked about systolic, and how systolic is when your heart relaxes in between heartbeats and fills your thing back up with blood before it pushes out again. So GLS is looking for how good you are at relaxing your heart in between the times you send blood out of your heart. And so you want a high GLS or a stable GLS. You don't want a low GLS. A low GLS means your heart is maybe not able to pump or relax as well as it should in between. So they found that all 5 patients did well with that. They made them run on a treadmill. And when they ran them on a treadmill, 3 of the 4 patients had improvements before and after doing therapy. And there's one patient who they did cardiac biopsies on. They had a cardiac biopsy from long ago, like 6 years ago before they did therapy. And they did a biopsy 6 weeks after they got their gene therapy in 26 weeks. And they saw that the gene that they put in through gene therapy was in the heart cells. So that was good. And they saw that the GL3 was less, and that was also good. So up there, you can see the one patient they looked at who had the gene therapy was in there, the gene was in there, and the GL3 was less than it had been 6 years ago. So that was good. I also have here the graphs that we're looking at the same way we looked at the before ones. So serum AGA, so that's your alpha galactosidase enzyme. And you can see in this case, the normal range isn't on this one. I thought I picked one with the normal range. Hold on. So this is nanomoles per hour per milliliter. And then, sorry, I thought I was looking at a different graph. Anyway, so this is a log. So this isn't the same as the ones we were looking at before, but you can see that when people got infused, they went higher than baseline out for several months here. Now there's one patient who went up and then went back down, and he's hovering about 0. So basically he went back to baseline. It didn't work for him. And one of the things that Mark Thomas said when they were presenting is this one patient had really, really high antibodies to alpha galactosidase A enzyme from the time he was infused. And so they're concerned that the reason that patient 2, the one who went up and back down to normal, normal being back to 0, basically. The reason that they think he had that was because his body made so many antibodies and totally fought the enzyme production from the gene therapy. If you look at the serum GB3, remember we wanted to go down or be straight. You can see that some went down and then some just stayed straight. And that patient 3 didn't have many values after, so we can't really see if he's gone up or if he's just went back to where he was before he started. So bottom line, in at least 1, 2, 3, 4 patients we see here, their enzyme level went above where they started and was staying above where they started, which is good. And their lyso-GL3 for those 4 went down and seemed to stay stable, or at least is staying as stable as they can right now. So that's good. That's all good things. Now, the one thing that they did talk about, and this diagram is not from the presentation, this is from somewhere else because I want you to understand what we're talking about. There were 3 people who had something called atypical hemolytic uremic syndrome. So basically, this is when your immune system gets upset that you've just given it gene therapy or given it something else that it's reacting to. This can happen not just in gene therapy, but other things. And this is a known complication of gene therapy, and it's something that's the reason that they were giving people steroids before they did this, because many gene therapies, even those that are approved, have a risk of having what we call atypical AUS. But in this study, 3 people did have AUS, at least the ones reported in this one. And what that means basically is your body gets very grumpy. And it is almost as if your veins say, I'm not happy. And the red blood cells kind of sneak out and they get collected by the kidney, which causes problems for your kidneys and then can cause you to feel bad. And it's because your immune system is really, really upset. And so 3 patients temporarily had this happen to them. They got treated and these 3 patients recovered fully. And they talked about this in the study, but because they had these 3 patients whose immune system had this reaction, they had one who didn't, but they're changing what they're doing to dampen the immune system before they give gene therapy. So the study was on hold for, I think, maybe about a year while they talked to the FDA and figured out how to give medications to dampen the immune system. So this is not a side effect they see after dosing. So I don't know that they're recruiting again yet, but it was just basically, this is a phase 1-2 study where you figure out what happens and then you try to fix it. It doesn't make it fun while you're in the study. And we're really grateful to anybody who's willing to do one of these studies and basically, try something new that could cause, some discomfort or some problems. So again, the 3 people in this study have recovered back to where they were at baseline. But that's why they've stopped recruitment for a bit to try to figure out what to do, because their other results were nice. So they want to see what they can do with this therapy. All right. So that's all I have for you. And it is the 8 o'clock hour. So I'm happy to answer some questions. I do see one question in here that says, have you heard any information about intake of omega fatty acids helping support cells that are damaged by Fabry in the heart? I have not. They have been looking at different things like anti-inflammatories, which try to help the body settle down, the immune system settle down a little bit to see if that will help the heart and the kidneys. And in fact, there's some medications that are prescribed for diabetes, and their job is to do just that. Not like omega fatty acids, which, are pretty much a good supplement for many other things. But I haven't seen it with Fabry specifically and damage in the heart. But watch this space. They're trying to come up with other things that might help the heart more and the scarring that's in it. So, and of course, the heart and the kidney are so connected. It's a good idea to treat them both if you can, right? What else can I answer for you guys, or other thoughts on this? Well, I just appreciate all your attention tonight and listening to me talk about the pieces that I thought were important or might be useful to you as you go through your Fabry journey, and talking to your doctor about some of these if they're interesting, or just being glad that people are really listening to people with Fabry disease and understanding Fabry better through your eyes, as well as, doing all these studies where we inject things in you and see what happens. So.
Thank you, Dawn. Thank you everyone for joining us as well. If you have any questions, feel free to email me, and I can always ask Dawn and we can get back to you. But I think just wanted to echo what Dawn said, which is there is a lot of hope, and there is a lot of, it is pretty amazing to be at World and to see what's going on and to see, the posters and the researchers and everyone who dedicates their time towards this. I think that always gives hope, but it also just makes you feel better knowing that that's happening. So, and Dawn, thank you for being one of those people.
Always, of course. If you wanted another view of things that happened at World, Rob Hopkin did a really nice summary on some slightly different things for the Fabry International Network, and I believe that's available on their website too. So you can learn all about World from multiple viewpoints.
Perfect. Thank you very much,
so
everyone.
much. Bye. Have a
Good night, Dawn. Thank you.
Bye.
Bye, Jack. See you, Gail.